Anyway, thank you so much for coming, and I guess we'll start with Congressman Weiner.
Let's go, Weiner! Great. Can you hear me okay? I've got a laptop here. Can I play anything on this? Does this make anything? This is a great opportunity for me, and I want to thank Yale 21C and all of you for being here. This is the fact of my life, this laptop here. I can't move this, I guess, right? Or can I just do this? Is that going to get anything on play? First of all, I do want to thank Yale 21C and all of you, and Betsy for being here as well. You know, look, we have basically three problems we're trying to solve as a country. Two of them are relatively easy. One of them is very difficult. Two of them, we have basic consensus that we have to do something. And the third one, which is the tough nut, is the one that there's been a lot of shouting and yelling about. The three problems are, first, we have 45 million or so people in our country who don't have health insurance. We don't have 45 million people who don't have health care. Everyone has health care. Because whether you're insured or not, if you get hit by a car out on First Avenue, an ambulance is going to come, they're going to pick you up, they're going to patch you up. That's the way it works. The problem is that for a lot of people, that care, some of it gets paid by that person, but a lot of it gets paid by those of us who are taxpayers, and a lot of it is simply absorbed by hospitals like this. It's an untenable dynamic. It's untenable to the tune of about $2.5 billion each and every year here in New York City in additional taxes that we pay for the uninsured and the underinsured. And for people like me, who represent districts in Queens, we in Queens today have 3 fewer hospitals than we had just a year ago because of all of the unpaid bills getting passed along to local hospitals. And it's got to be changed. If you don't believe it's got to be changed because of the economics involved, it should be changed because of the health care that we're providing to those people. It's terribly inefficient care. Having someone show up at a hospital emergency room with 104-degree fever with swine flu is not nearly as good as having them maybe get a checkup when they're starting to feel a little bit wheezy and prevent them from infecting others, and also stop them from getting ahead of the real emergencies that belong to hospital emergencies. So the first problem we need to solve is we have to figure out a way to how to provide coverage for the people, health insurance of some sort for the people that don't have it, so they're not going and getting the least efficient, most expensive, unpaid for care. That's problem number one. Second problem is, for all of us that have health insurance, which is an overwhelming number of people in this country, the quality of the care that they get is often lacking. You know, we've got terms like pre-existing conditions. We have people who are not treated very well. There are people who are not covered practically at all. Someone like my father who retired before he was 65. Sure, he theoretically had access to health insurance, but he had to wind up paying an enormous amount because when you're a 60-year-old guy, frankly, the amount of health care that you're going to be able to get at a reasonable cost, $16,000, $15,000, $17,000 for someone like him, was effectively prohibited. So the second problem we have is how we make sure that people are treated well by their insurance company. The third problem is a big one. It's the mother of all problems, and that is how we contain the cost spiral that we're on now. For individuals, we're paying $1,000 more just about every single year for health insurance. For the government, for you, the taxpayer, the cost for retired federal, state, and local employees, for local employees that are on the job now, you are the employer for all of those people. As costs keep going up and up and up, it's an unsustainable dynamic to the point where it is having a stifling effect on the economy. I mean, let's face it, if someone says, I get enough money to go out and hire an employee, but you know what? 30% of it is going to go for their health care costs. It has a real downward pressure on the economy. And if you doubt it, just go take a look if you're really having trouble sleeping and you're all done reading Ben's columns. Go read the GM filing, bankruptcy filing. It talks about the legacy expenses that it has, even though it has the same per employee cost of, say, Toyota, the legacy cost of all of its retirees providing health care is a stifling problem. And of course, it's stifling for those of us who pay the bills for about 40% of the world, the Medicare, the Medicaid, the Department of Veterans Affairs, Bureau of Indian Affairs. These are taxpayer-expended things. The costs are now reaching a point where we're 17% of GDP. In 10 years, it's going to be nearly double that. It's unsustainable. So that's the tough problem. In the first two things, it's relatively easy. You give a subsidy to someone, you say, go try to find health insurance. The second one, you say, we're going to set these rules, you're not going to be able to drop them. When people say there's 80% agreement, they generally mean those two early problems, there is broad agreement. Now, I can tell you, though, that in the third problem, I don't think President Obama goes far enough. Some people in this room think he goes too far in proposing something called the public option. Now, even the people clapping for the public option are going to be disappointed with what's being proposed now. The public option is not for anyone who's on Medicare. They're, for the most part, not going to be for anyone who's on Medicaid. And they're going to be for virtually no one who has insurance through their employer right now. Why is that? Because if you have insurance through your employer right now, and you decide, you know what, I want to go shop in the open market and try the public exchange, the employer portion that they're paying for you now at your workplace won't follow. So effectively speaking, you won't be able to go into that public option. So it's a relatively small number of people. It's only those who have no insurance or those who are dramatically underinsured, meaning their employer offers them something that's so stripped down, it doesn't even meet the minimum requirements. Now, that public option that's been the source of all of this discussion, combined with the idea of trying to get people, the private insurance companies, into a pool, and then you get to choose which of those things you want, that element of competition is what a lot of people are banking on to hold down costs. Some sliver of competition in one sliver of the marketplace. I believe, ladies and gentlemen, that doesn't go far enough. I believe that we have an example of a true robust public plan today. In fact, as I said, about 40% of the people in this country and about 47% of all of our healthcare financing goes through, hold your breath, a single payer, government funded, government run, government administered healthcare plan. Now, it is not a government controlled or a government plan per se, in that the means of production are still the doctor. The doctor still gets. The doctor still treats the patient. The only thing we're arguing over here is when you give your money in taxes or you pay your money in premiums, who gives it to the doctor? Is it going to be your insurance company or is it going to be the public? Is it going to be the Social Security, Healthcare Finance Administration, or CMS? Now, I want to put up a chart. Do we have the chart up? Just put up the pie chart up. Now, I just want to tell you one quick thing. I want to touch on one quick thing here. First of all, you're going to hear people who say, that's great, thank you. Look at this. Look at this. You got one of these, Betsy? All right. This here, Medicare. Single payer, government administered, about 3.5% overhead. This part here, private insurance, $854 billion, which is about 30% of the total nut here, up to 30% profit and overhead. If we want to save money, maybe we take out the shareholder bit here. Maybe we take out the advertising. Maybe we take out the bonuses for the executives right here. By the way, the guy who runs this, $175,000 a year. The guy who runs this, on average, about $4 million a year. The only point that I'm making here is if we really want to get that third piece solved, if we want to hold down and contain costs, the way to start is with up to 30% of this number that is getting nothing. And I say getting nothing because it is not doing anything, it's not providing any health care, it's not giving you any checkups, it's not doing any diagnostics, it's not operating on anything. Unlike car insurance, this isn't even apportioning risk. Because unlike car insurance, where everyone is in, from 95 to 17, they don't cover anyone who's over 65. They'll drop anyone who's got pre-existing conditions, and generally do everything possible to endeavor to do what businesses do. Take in as much money as they can, pay out as little service as they can. Now, while you're comparing these two numbers, 30% overhead profits, 3.5%. And for those people who are going to try to scare you into what the public option might look like, you don't have to fantasize about Canada, about Britain, about Europe. You can just look at this and say, Medicare, how is that administered? Anyone trying to deny anyone care? We never heard of the term pre-existing conditions until we introduced private health care into it. Is anyone trying to take efficiencies that you get there and use it to pull the plug on grandma. No. If you want to figure out what a public option might look like, take a look at Medicare, take a look at Medicaid and SCHIP, take a look at DOD, VA, and Department of Indian Affairs. I want to make one other point, and then I want to address in advance a couple of the things that Betsy is going to be bringing up. First of all, get the idea out of your head that this is a free market. It's not. Right now, I fall down on this stage, and my appendix first. I can't think of a better place, but if that were to happen, I don't have any of the power of being a consumer. I don't get to say, you know what, I'm not going to do an appendix today, give me a liver instead. I don't get to say, you know what, appendix go down in price in December, so I'm going to wait a little bit longer. I don't get to say, you know what, I don't think I'm actually going to get health care, I'm going to go to medical school and learn how to operate on myself. None of those traditional elements of a free market exist. And I'll go one step further. I have a very fortunate situation at my workplace that my employer, you, come with many different choices and say, you know what, choose a health care plan you want. For 82% of this number, workers don't have that choice. Their employer walks in and says, we've got Oxford. Here's Oxford, I'm going to pay 60, you're going to pay 40, that's what you get. You don't get to say, oh no, I want to shop around, I want to make Blue Cross better. You can do that, but you leave the employer 60% on the table, so practically speaking, you don't have any kind of mobility. So when you hear people say, let the marketplace work, they mean, let these guys keep making $200 or so billion every single year. And I want to question why. So now I want to conclude by talking a little bit about this debate. You know, it's been good. I had 13 town hall meetings. I've had a lot of people yelling at you, but I think it's basically good. There have been elements of this debate that have been just bad. And unfortunately, the woman I'm debating today has been part of that element of this discussion. You don't need to take it from me, and I don't need to go through. You can get today's New Republic, titled The Never-Ending Lunacy of Betsy McCaughey. You can ask PolitiFact, which has a liar scale. They call her claims pants on fire. John McCain's advisor said that the charges amounted to fraudulent scare tactics. The head of bioethics at Boston College criticized them. Even, there's an article written about it called The Lie Machine. Even my friend, Ezra Klein, the Washington Post, she's a liar, but she's an exciting liar. I guess that qualifies as a compliment in this context. And even my friend John Stewart said it's hyperbolic, in some cases dangerous. But I want to offer you this listener's guide to Betsy McCaughey. She'll talk page numbers. The page numbers will have nothing to do with what she says there. She'll quote sections. You can go look at the sections. She's had a little problem today because she's actually debating someone who read the bill, helped write the bill, and was there for all the hearings on the bill. So when she says page 16, and she says it says you're going to lose your care, page 16 actually says we're going to set minimum standards for all health insurance plans. When she says page 425 says death panels, well, by now you all know the death panel claim doesn't say that. It says for the first time we're going to reimburse for having conversations about end-of-life care with no sanctions, if the doctor doesn't comply, except for what's in our state law, which hopefully is being followed. When she talks about the Cantwell Amendment today, again, no correlation with the truth. But there is a theme. The theme is whenever there's a discussion about saving money in Medicare, Medicaid, or anything, she says someone's going to die. When there's any discussion about having an efficiency, someone's going to die from that too. When there's anything to do some research and aggregate information, someone's going to die from that. Now, she didn't always make this argument. In 1995, when she proposed as part of the TAC administration $1.3 billion in cuts in Medicaid, those were efficiencies. But today, they're apparently dead. Thank you. hold that up again?
Oh my God. Thank you. Well, I'm very glad to be with you. Weiner. Despite what he said, we actually have an area of agreement. I share his view that when people cannot afford health insurance, when Americans cannot afford health insurance, we should provide help for them to purchase it. The President has pledged to cover millions of uninsured Americans. The Congressional Budget Office has already alerted us that when people who were previously uninsured have coverage, they will use about twice as many doctor's visits and about 70% more health services than before. The President has also pledged to reduce the annual growth in healthcare spending by 25%. Slowing the growth of healthcare spending will force cuts in hospital budgets. It will spread nurses even thinner. It will mean less diagnostic equipment and other equipment and waits for treatment. This, when millions more people will be accessing the system. Now this bill, H.R. 3200, which Anthony helped to write and which presumably he is supporting, has two goals stated right on the first page. One is to cover the uninsured. I share that goal. The other is to hold down health spending. These two contradictory goals will mean a lower standard of care for you and government interfering in the decisions your doctor makes. It will also be a body blow to New York's hospitals, healthcare workers, and patients. The President said on September 9th, when he addressed the joint sessions of Congress and the nation, if you have a health plan you like, you can keep it. But this bill says that you will have to give up your plan and enroll in the plan the government wants you to have. If you get your insurance through your employer will have a grace period, and then will have to put you in the qualified plan, the plan the government has designed. If you get your insurance yourself rather than through your employer, you won't have a grace period. You will have to switch into a qualified plan the minute anything in your current insurance contract changes, a copay, a deductible, or any of the benefits. When you go to file your taxes, you will have to attach proof that you are enrolled in a qualified plan, and if you can't, you could be fined as many as thousands of dollars. Now, 18 months after this bill or something like it is passed, a Health Choices Commissioner appointed by the President and 5 medical advisors appointed by the President will make the important choices about your care, what your plan covers, how much leeway your doctor will have, right? And how much you will be legally required to pay for your plan. That's like a banker holding out the loan agreement and saying, sign here today, and 18 months later, we'll fill in the interest rate and the terms of repayment. Is that reform? Because so many of the important decisions are delegated to presidential appointees, I'd like to introduce you to two who are already playing an important role. Meet Dr. David Blumenthal and Dr. Ezekiel Emanuel. David Blumenthal admits that government controls will mean patients and doctors are dissatisfied. There'll be less access to new medical devices and treatments, and waits for treatment as well. But he calls it debatable whether the timely care Americans currently get is worth the higher cost. Now, Ezekiel Emanuel talks very bluntly about what it will really take to achieve cost reductions and cost savings. And he says it will not be pain-free. Vague promises of savings from increasing wellness and prevention programs, curbing waste and abuse, expanding the use of electronic medical records, and improving quality, things the president talks about often as ways to save money, he says are mere lipstick cost controls, more for PR and show than for real change. Emanuel is right. The CBO report last December says that these things will not achieve real cost reductions. Emanuel argues that the Hippocratic Oath is largely to blame for what he calls the overuse of medical care. He says we have to redefine a doctor's ethical obligations if we're to save money. Said the trouble is the doctors focus too much on the needs of their own patient rather than considering the impact on society. Doctors, he said, should be retrained to ask themselves, is the money I'm spending on this patient really worth it? Blumenthal and Emanuel argue that government controls should be put into place to curb your doctor's leeway in order to reduce costs. The framework for those government controls was slipped into the stimulus bill, passed into law last February 17th. The bill provides, the law now provides, that protocols will be delivered to doctors electronically on what the government deems appropriate and cost-effective care. And doctors who are not meaningful users of this new system, meaningful user to be defined totally at the discretion of the Secretary of Health and Human Services, and the definition can be made, according to the bill, more stringent over time. Doctors who are not meaningful users of the system will face penalties under Medicare and Medicaid. Now, when I warned last February that this would mean the government telling your doctor what to do, factcheck.org and CNN said, no, it's not true. The government isn't going to try to control your doctor's decisions. But Dr. David Blumenthal settled that debate. In March, he was appointed to head this new computer-guided system of medicine, National Coordinator of Health Information Technology. And on April 9th, in the New England Journal of Medicine, he explained that embedded clinical decision support, his euphemism for computers telling doctors what to do, would be used to reduce costs. And he actually predicted that some doctors would be upset and consider the controls too tight and would ask Congress to change the law, right? Or would simply reconcile themselves to accepting the penalties rather than denying patients the care they needed. Now, it's a good thing to deliver research to doctors on the newest findings in order to keep them up to date. It's hard to keep up with the pace of medical knowledge. But you don't want your doctor having to choose between you and avoiding a government penalty. And the fact is that guidelines based on this research are for the average patient, not the elderly patient, not the patient with comorbidities. It is not reform to force doctors to make that choice between their patient and avoiding a government penalty. This bill, in addition, is a medical assault on seniors. This bill, supported by between $1 trillion and $1.6 trillion is paid for partly with tax hikes. Everybody's heard about those. But also with a $500 billion reduction in future Medicare funding. This at a time when 30% more people will be enrolled in Medicare. Almost a 10% reduction and 30% more people. Those numbers do not add up. It's going to mean less access to inflation, food inflation, these are the procedures that have transformed the experience of aging over the last 40 years and freed elderly people from the crippling effects of arthritis or from being so out of breath that they're trapped in a nursing home because of clogged arteries. There is a better way. Anthony and the President should throw out this $1,000. Established the entire federal government in 18 pages. Cover the 12 to 15 million Americans who actually cannot afford health insurance. Right? It is so important that this be in a short bill that's readable. So much of the rancor during the current debate is because those of us who actually read the bill and point out its dangers are answered with vague reassurances, and the public doesn't know what to believe or whom to believe. We could cover those 12 to 15 million people for the next decade with the $500 billion in unspent stimulus funds still sitting in the pot. We could do it without cutting Medicare, without forcing you to give up the health plan you like, without additions to the deficit, and most importantly, without dismantling American medicine. Now, on September 9th, when the President addressed the nation, he didn't say one good thing about American medicine. I'm very proud of it. I'm in hospitals almost every day. Wonderful places like this where I see doctors and nurses literally rescue patients from the brink of death. If you are seriously ill, one of the best places to be is in the United States. A woman diagnosed with breast cancer in the United States has over a 90% chance of surviving. In Europe, it's under 80%. The World Health Organization rates the United States #1 out of 191 nations for responsiveness to the needs of patients. And if you or someone in your family has what's considered an incurable illness, this is the nation of hope, where the new breakthroughs occur. Since 1950, the U.S. has won more Nobel Prizes in medicine and physiology than the whole rest of the world combined. And that single-payer country to the north, Canada, not one. Is this standard of medical excellence and innovation sustainable? The President says no. Max Baucus says no. Anthony says no. But, in fact, the evidence proves that it is. Americans spend more on health care because they can afford more. 90% of the difference in per capita this is by the way from health care economists in Weiner. 90% of the difference in per capita health spending between the United States and Europe is due to higher incomes per capita in the United States. We spend more because we earn more and we get more for it, including higher cancer survival rates, lower death per capita from cancer. Now, here is the question. We get more, but what about those soaring premiums? They are soaring. Politicians are largely to blame for that. Politicians in the laws adding more and more mandates to health insurance plans. More and more requirements, like marriage counseling, for example. It's like passing a law that the only car you're allowed to buy is a fully loaded luxury sedan. Some people can only afford a subcompact, right? That and the fact that people now pay for everything with insurance rather than paying out of pocket for routine costs like going to a doctor. At one time, as you can see, not so long ago, people paid for about a third of their health care out of pocket. Now it's down to 15%. Your auto insurance premiums would also be soaring if they suddenly included every trip to the car wash, every oil change, every tune-up. But in addition, the growth of government sector healthcare, government programs, has also pushed up your private insurance premiums. Let me show you how. For every dollar of care delivered, Medicare pays 93 cents to the hospital. Medicaid, 86 cents. And hospitals like this are able to stay open because they squeeze $1.32 out of the private sector insurance companies. You're paying a tax because of that. When you write your check to your insurance company, or your employer does, on average, $1,788 of that premium is going to offset the shortchanging that the government does because in these public programs. Now, Anthony and many other people are calling for a public option. Chuck Schumer, Kirsten Gillibrand. They say it's essential. In fact, though they argue that that public option will create competition and lower prices, it's actually going to suffocate competition and raise private premiums because, let's go back to that pie chart for a second. We know that Medicaid is going to increase by 10 to 11 million under this bill. Medicare is going to increase by 30%. Then, if you add the public option, which is going to pay hospitals and doctors at Medicare rates, doctors at Medicare plus 5% initially, but hospitals at Medicare rates, you're going to have almost all of this pie chart paying hospitals less than the cost of care and only a little sector of private insurance. It's going to drive up premiums and it's going to force hospitals to operate at a loss, lay off nurses and technicians, and offer a scarcer version, a more lower quality care. Now, right. This bill is also devastating to New York. Slowing the flow of dollars into healthcare will cause layoffs in New York because healthcare is the largest. Hospitals are so important to New York's economy. New York is the hospital capital of the nation. We treat more patients here than any other city. We employ more people in hospitals here than in any other city. 57 hospitals in the New York area. In addition, the specific provisions of this bill punish New York. For example, the shift from funding specialty care to primary care will starve the great specialty departments at New York Hospital. The provision to pay Medicare, to pay hospitals in all parts of the country the same low rates as in places like Minneapolis will punish New York, which is a high-cost area, and the public option will be the final blow, forcing New York's hospitals to operate at a loss. So what I have to ask Anthony is this: how can you support legislation that is so punishing to New York's hospitals and healthcare workers and patients? How can you support legislation that funds coverage for the uninsured by slashing Medicare services for seniors? That's like snatching purses from little old ladies. You represent this city. You represent New York, the hospital capital of the nation, and you should represent us even if it means standing up to the president.
Leave that out there. Leave that out there. Yeah. I'm fine out there. You know, I feel like I'm debating a pyromaniac in a straw manufacturer. You know, well, let's if it's too much to introduce you guys. All right. Well, I don't know.
This is his speaking time.
Let me start here. Let me start here. You know, let me start here. I'm going to try to quickly tick through the many mistakes that were made and then try to get us back to the point about how we save money in the system. First of all this talk about getting a qualified plan, you got to make sure you get a loser's care unless you're in a qualified plan. Every plan offered in New York is already a qualified plan. So you don't have to panic that you're going to lose your plan. Secondly, this notion that that last slide that Medicare, where's the thing? The Medicare in New York is going to be made the same as North Dakota. It's not in there. Medicare plus 5% isn't even in there. It's untethered to anything. The public plan is going to have to compete just like everyone else. Now, it is true that my idea goes much further, and I think we need to strengthen the public plan, but the description of what's in the bill is just not true. This notion that the stimulus snuck in this agency that's going to take away, what is it you say, old ladies' pocketbooks or something? In fact, that was an agency that was created in 2004 to help implement the technology to help hospitals communicate with doctors so that they don't have to constantly do test and retest. They communicate via electronic documents. That was what was split. The notion that somehow we're disincentivizing specialists and forcing everyone to get primary care, no. But if you're going to provide insurance for another 20 million people and you're going to try to keep them out of emergency rooms, it is true. In the bill, we incentivize and help offset the debts incurred by primary care physicians. That is true. I assume that's the problem for it shouldn't. The problem is basically this. If you heard again and again and again and again, there are references to efforts in the bill to make healthcare more efficient and to make it so that we cut the growth of healthcare spending to a level that is maybe, I don't know, half the highest that every other country has. I mean, we are not, the idea is not to deny people care. It is kind of like Buddhism. It's not whether we're going to have change. It's what kind of change we're going to have. We can keep going on this path if we want, and there are a lot of people who are deeply invested in the status quo. Yeah. That $800 billion a year, those people from the healthcare industry are deeply incented in keeping things the way they are. Now, Betsy points out again and again, she makes a common mistake that a lot of people make when they're unfamiliar with the legislative process. And it reminds me why she got 2% of the Democratic primary for governor. But there is a $422 billion increase for Medicare in the bill. $422 billion increase for Medicare in the bill. Now, we do things to get savings in the bill, and some of them you're not going to believe. I mean, sit down for this part, folks. Right now, Walmart offers $4 prescription drugs. How do they do it? They go to the companies and say, we have 1 million customers. We want the absolute lowest prices. Nobody's as big as Walmart, right? Medicare is as big as Walmart. We don't compete for the lowest price. That's $115 billion right there. Now, apparently, according to my good friend, that's going to require, what was it, Granny to lose her pocketbook? People being thrown off? No, that's smart saving. Now, people do suffer there. Pharmaceutical companies are going to take a little haircut here. And I know pharmaceutical companies support the Hudson Institute, but that's not what I'm fighting for. Right now, if you check into this hospital with a broken hip, you get reimbursed. Medicare reimburses this hospital about $900 a night for a senior citizen. Do you know how much we reimburse if someone comes in, a local, let's say the Met Council on Jewish Property goes in and puts a hammer on someone's bathtub so maybe they don't fall? Zero. We incentivize the most expensive care, and we don't incentivize the less expensive care that keeps people out of expensive institutions. Now, if you believe having that in the bill means you want Granny to die, and I notice no talk about that, so at least she learns a little bit. But if you think that that means we're pushing people out of care, that's just wrong. And by the way, I do represent seniors in New York. I represent seniors who don't have care. I represent middle-class people. You know, of all the people that are uninsured in this city, 70% of them are full working-time jobs, but they can't afford health insurance. That's wrong. I work for those people. I work for the people in hospitals like this that have the rates dictated to them by insurance companies who then take 25-30% in profits. But I don't work for those insurance companies. I think the time has come for us to say, as I say, that the light comes in. You want scare stories about what a single-payer system looks like in other countries? You don't need to, Betsy. You can look at Medicare, the program you claim to care so much about. A single-payer, government-funded, government-run health care plan that gets it right, that you don't hear complaints about pre-existing condition, that has a 96% approval rate among the people that get it, and has a 4.5 out of 6 stars from hospitals like this, because it's a program that works. We should expand that. Why get it when you're 65? Why not when you're 55? Why not when you're 45? Why not when you're 35? Guys at 64, we shouldn't fight for him? What about the family that's one of the 17,000 every single day that loses their health insurance? We don't fight for them? What about the doctor that has 7 or 8 or 9 inboxes for different insurance companies, jerking them around all day long? We shouldn't fight for them? Don't you think we should fight for the taxpayer, negotiate for the best prices? Don't you think we should fight for patients who are being told they have a pre-existing condition we're not going to cover you? Don't you think that we should fight for a city like New York that has $2.3 billion in extra taxes from the uninsured? That's who I fight for. That's who I'm paid to fight for. And I'm going to keep on doing it. I don't care how many times you tap on a version of the bill that we didn't even vote on. You really should know that. We voted on the manager's amendment. That's not it. Every time you tap on that bill, it doesn't change one iota. And that is that every day in this country, so long as we don't solve this problem, we're paying too much in taxes, we're getting too little in wages, we're getting too little in reimbursement rate coming back to hospitals like this. That's the plain fact. And you can point to sections of the bill and fabricate completely what it means, but until you start realizing that we have to do more than just bid for the insurance company's overhead. Not a single point in 20 minutes did she say, you know what, maybe insurance companies shouldn't take 30% overhead in profits. You know what, maybe it's not our job to defend the shareholders of insurance companies. Maybe if Medicare, we can't cut any money out of Medicare, she says, and yet for some reason she doesn't want to extend it. Why? Where's the wisdom? Where's the logic in all of that? And that's the question that I have. And I just want to say to all of you, ladies and gentlemen, if you think for a moment that being a representative of New York means that I want to, what was it again, take the purse away from a senior citizen or something like that? No. This is a problem that we have to solve. And 44 years ago when we created the Medicare system, we did something pretty smart and pretty bold in this country. That has worked. Does it have a financing problem? Yes. But much less of a financing problem in private insurance. The rates of Medicare, even though they can handle only the sickest and oldest Americans, 65 and older, they have a smaller rate of growth than private insurance. And when you look it up in that chart, she says, and I don't know why it was a circle and a pie chart. I mean, I don't know what it was supposed to all add up to. But you look up, it's $1.32, take 32 cents, that's profits. For the insurance company. For the insurance company. And if you think that the policy in this country should be, how we defend those poor insurance companies, that's the same kind of wisdom when we discovered $800 toilet seats in the Department of Defense. We would have said, it's poor toilet seat companies. Well, we've got to make sure they survive and their shareholders do well. I think that we have to realize for a moment that we have two parallel experiments going on. One private insurance and one public insurance. And the public insurance has lower overhead, even Betsy says she doesn't want to cut a dime out of it. lower overhead, better efficiency, better quality of care for those getting it, more satisfaction on the part of doctors. And this debate has come down to, if it's your tax dollars, if it's your money, why you're taking it from your pocket and giving it to doctors, why give it to insurance companies 20% or so? Why do that? What are we getting for that value? And that's the argument behind the public plan, and more importantly, the argument behind the single-payer system.
Under the public option, Medicare rates will be paid to the hospitals, Medicare plus 5% initially to physicians, and then just the flat rate. So I invite you to come over and take a look at that.
Right. Reading the wrong bill.
Secondly, Anthony has said that we have two experiments going on here, the public sector experiment, Medicare, and the private insurance experiment. That is not true. Medicare is succeeding because, like Medicaid, it is dependent on the private sector for that cost share. It's not reduced by private insurance. Plus, billions of dollars in startup costs to fund this public option. That's not the point here. He has said that we must slow the growth of healthcare spending. Let me remind everyone here that 2/3 of that annual growth is due to innovation. Walk into an electronics store and you will see things that didn't exist 2 years ago. Walk into a hospital and you'll see the same thing. New medications to undo stroke damage, new ways to conquer arthritis, new ways to spare heart attack victims from death. Right? The President's advisors, David Blumenthal, Victor Fuchs, say that the best way to reduce healthcare spending is to slow the development and use of new technologies. That would hobble medical progress. You know, today the United States won 3 more Nobel Prizes in medicine and physiology. The other 2 emigrated here from single-payer nations because they could do their work here, right? Now, single-payer government, single-payer health insurance programs hold down costs by limiting care and forcing patients to wait for care. Take a look at what Michael Rollins, head of NICE, the British Rationing Board, explains that we spread the care around to everyone, but we can't take care of the most seriously ill patients with renal cancer or breast cancer. That's why Britain has the lowest cancer survival rates in Western Europe. And the OECD recently issued a report saying that single-payer nations control costs by making patients wait. For example, a 6-month wait in Great Britain for inpatient treatments. That's unacceptable. Unacceptable. Yes, I would like to already find health care and health insurance in the U.S. And here's what I'd like to do. I'd like to cover the uninsured. I'd like to spare doctors from unmeritorious lawsuits that are driving up costs. I'd like to correct insurance company abuses that leave patients without care when they've paid their premiums all along. I'd like to create a risk pool in New York State, like 35 other states have, so that people with pre-existing conditions could get health insurance affordably. And I'd like to free people in New York to buy health insurance across state lines. And have a good health plan, because they would be freed from the unwise policies of this state. In summary, Anthony is supporting legislation that will cripple New York's hospitals, healthcare workers, and patients. He should be representing us instead of kowtowing to the president. Thank you.
I don't know what that's about, but in any case, thank you so much for staying within the time limits, which is remarkable. I didn't mean to like jab anyone, and thank everybody for being as civil as could be expected. I guess there were lots of really good questions, some of which are in here, some are coming from me. But one question I was hoping to ask Lieutenant Governor McCaughey. And this, I covered New York politics for years. That's how I think of you. I wonder if you could compare and sort of what you make of the reception to your 1994 article, which the White House hated. I think they issued an 11-page rebuttal of, but was received, I think, respectfully, got a National Magazine Award with the reception to your work today, which I think the New Republic formally recanted the 96 article, apologized for running it as a piece whose title Anthony quoted today. You were tossed off, or you were pushed off a corporate board over the work. Is that not true? That was reported. Excellent.
I was not pushed off a corporate board. I resigned from a corporate board before the debate became heated in order to avoid any appearance of conflict of interest and to spare that company any controversy. It is not true that I was pushed off a corporate board.
Okay, but I guess I wonder more broadly if you could compare the reception. I mean, do you feel that?
Well, I think that there's a more rancorous debate in the nation this time than in 1994. There's no question that it seems more partisan and more divisive. And it seems unfortunate to me that any of the participants in the debate on either side would be subjected to personal criticism when the subject matter is so important. And we have such an important decision to make.
Congressman, I guess I wonder. I have a couple questions about the public option. There, I think people on the left and on the right who think that it's a distraction. I mean, and I don't know. I guess my first question, which I hope you'll answer at the end, is whether you will vote for a bill that doesn't include a public option. Whether you'll, lobby your colleagues on the left to do that or not. But I guess more broadly, I mean, as you said, what's in the bill has been really cut back. It doesn't have the kind of bargaining power as being tied with Medicare that you had hoped. It's not going to cover a whole lot of people in the end, at least for starters. And in the meantime, there are these very heated negotiations going on over subsidies, over what percentage of property is going to get what level, what percentage of their care covered. I mean, I think as written in the bill, middle-income people could wind up paying $10,000 out of pocket for care. And so I guess I wonder, why is the public option the hill you're going to die on that, if it is?
Well, let me just say, and forgive me, perhaps I was rude, it's just sort of a gesture towards the bill that Betsy's been referring to was not the bill that was considered in the committee we had. It was immediately substituted, a chairman's mark was substituted. Right now, the public option is so watered down in an effort to get votes that the public option would, as I said, only be offered to people that don't have their own insurance. Which is already a fairly small number. And it would not have its rates tied to Medicare, despite what Betsy mentioned. So in fact, it's not going to say, well, that much money. I'm not saying this, the CEO says. I believe it needs to be even more muscular than this. But here's why it's important. If you don't have the public option, you really don't have the cost-saving mechanism to protect those people that are paying $800 million. There is no incentive on the part of healthcare companies to compete with one another on price. Now, Betsy mentioned a point that has come up a lot, and I think someone should answer it for this room. What about the idea of letting insurance companies go and compete over state lines? Well, all 50 states regulate insurance separately because of the antitrust exemption insurance companies have. In exchange for not having federal regulation, they're regulated state by state. Do you know how many states of the 50 states currently have a pending application for an insurance company to come in and compete in their state? 0. The insurance company in Maine has no interest in setting up a competing plan in Idaho. They have to sign up all the doctors, build the infrastructure. They don't want to do it, which is another reason why having a public plan that would look a lot like Medicare, won't have to be started is at least a tiny sliver of competition, a tiny little bit. But in answer to the question, is this a hill I'm prepared to, whatever the metaphor, we're getting very heated.
There's an old lady whose purse you're prepared to send.
Yeah, I mean, it is not nearly what we should be doing. In my view, what we should be doing, and I have said this repeatedly, we should take the robust public plan act. You don't need to go to Canada, Betsy, you can just look at ours, where no one's getting pulled the plug. There aren't great long waits. It's called Medicare. And rather than say 65, let's say 55 after 5 years, 45 after another 5 years. All those people who just came out of college, who don't have coverage under their own plans, make them eligible. That's what we should do. But I think the reason this is so important is only
But you'll vote for a bill about public option?
well, let me just look. I think that it's got to be stronger than the House committee came out with, and certainly I don't care what the caucus committee comes up with at this point. It should not become law. It's not strong enough. But I will say this. Millions of new people are required to go buy private insurance. The very least we can do for those people is provide them some competition.
Let me clarify that the public option is not competition because it is subsidized by the private sector. That Medicare pays less than the actual cost of caring for a patient, and the excess cost is slid over to be paid by those who have private insurance. The larger the public sector gets, the more costs are shifted onto the private sector, and it's a major reason that health insurance premiums have increased so much faster than actual health costs because of this cost shift as the public sector grows. Now, the bill says that Medicare will receive, that the new public option will receive seed money from the federal treasury to meet claims, as any insurance company needs money in the bank, but the capital here will be provided by the taxpayer rather than investors. So do not believe that Medicare or this option is like a single-payer system. It's subsidized by the private sector, and that's really critical.
Well, I wanted to shift on to something that got touched on in the debate, but end-of-life care. Lieutenant Governor McCaughey, you and I was interested in whether your position has been accurately represented. I think you called these counseling sessions which would be paid for, duly paid for under the plan, a vicious assault on elderly people, which I think, and
where did you get that phrase from?
I think you said it on Fred Thompson's radio show. So I might cite it wrong.
Because Anthony was wrong when he characterized that provision in the bill. If the bill were simply to provide that Medicare would reimburse for end-of-life counseling, it would have only required a line or maybe a paragraph, not 6 pages. Prescribes what shall be discussed in the end-of-life counseling sessions, not what may be discussed, what shall be discussed, including, just let me finish please, foregoing nutrition and hydration. And, in addition, though the word mandatory is seldom used in legislation, if there's a penalty for non-compliance, it's mandatory. And the penalty is here against the physician. It says that physicians' quality measurements and consequently reimbursement will be determined in part by the percentage of their patients who have living wells and the percentage who adhere to them. It's the adherence part that's troubling. I'm in hospitals a lot, and many people write a living will when they're healthy that says, I'd rather be dead than be on a ventilator. But when the time comes, they choose life. And their doctor should not be penalized because the patient did not adhere to the living will. It's so ill-advised that the Senate Finance Committee removed it from their draft. It's a dead issue, so to speak.
on the question of end-of-life care, an enormous portion of spending does in fact take place at the end of life. I think your debating partner here doesn't think that costs are in fact out of control, but I think you do. I mean, are there savings to be found, or shouldn't we pull the plug on grandma since it's going to be so expensive to keep her alive another day?
Well, let me say this. Since this portion of Betsy's argument has so been thoroughly debunked, and I would just encourage people to go read on their own. They can go to PolitiFact, and don't take it from me. You can take it from them. But how about now? You're now. I can tell you. Okay. All right. Be careful what you ask for. All right. Ready? Now these are the words. And they're all plain English words. They're not 6 pages. Listen to them, and you tell me what they say. Such consultations, and this is what will be reimbursed. Not what you're required to get, but this is what will be reimbursed. And because this was asked for and requested by insurance companies and hospitals, we realized that about 20% of all the lawsuits that Betsy says she wants to reduce are these conflicts between families, doctors, hospitals after the passing of someone over whether or not some procedure should or should not have been done. Every state in the union, including New York, has a living will, has a do not resuscitate order that's on the books. And by the way, Betsy, if you violate that as a physician or as a hospital, that's a breaking of the law. You don't want people signing up for something and then having doctors violate it. So that's not in this bill, that's in the law of New York State. But I'm going to tell you what will now be covered under Medicare, and you tell me if you think it makes sense. Such consultation shall include the following: an explanation of the practitioner of advanced care planning, including key questions and considerations, important steps and suggested people to talk to, an explanation by the practitioner of advanced directives, including living wills and durable powers of attorney and their uses, an explanation by practitioner of the role and responsibility of a health care proxy. Period.
No.
Next, Betsy, I'm going to have to ask you to be patient. And well, the problem that we have here is that while it's been universally debunked, it doesn't even, honestly, you can really go anywhere. There, the truth meter on PolitiFact, which is not partisan, they even spanked me a couple of times. They say truth to lie, and then they have something called pants on fire. This one had pants on fire, which is why it wasn't. Now let's talk about this for a second. Right now, pipe down. You're not in Stanford anymore. Pipe down. We are in a situation now that we have an enormous amount of end-of-life litigation going on. This doesn't require anyone to do anything. And Betsy, this is what makes it bad. Betsy knows it. She knows it. She knows there's no requirement that anyone actually get this. That's why it's called a liar with pants on fire. I didn't buy it to live back.
Would you like to respond to that? Did you want to respond to that? You can also move on.
I think it's more important for people to read the text of the legislation than to rely on all these critical pundits, most of whom haven't read the bills themselves before they come to their conclusions. And what I'd like to ask Anthony is this: since so much of this controversy, so much of this ill will stems from the fact that most members of Congress don't read the bills, don't have an opportunity. I'd like to ask Anthony if he is signed of the Read the Bill petition in Congress. H.R. 554, which is a bill that would provide 72 hours or more of time on the internet for any bill that's posted before it's voted on and debated in Congress.
Well, I've read the bill, and just last week. Yes or no? I read the bill, and just last week, we passed a motion in the House to make sure that we have 72 hours to read this bill, and I'll read it again. But how about this? Will you make the following commitment to me? That when you do read sections of the bill that are in plain English, that everyone agrees, says one thing, will you continue to spin yarns that don't make this debate any more rich? It simply does not say what you said. There is no death penalty. That's why you have scores that call you a liar. That's why you have that bias. This isn't a problem of people not reading the bill. In your case, it's a problem of reading the bill and then lying about what's in it.
Students, back to, sorry about this, high-minded policy for a second. One thing that intrigued me that you said was, those were all coming from audience questions, was,
But government controls to save money. Government controls are a blunt instrument.
is there another way to do it?
Well, let me just finish. The RAND study in 2003 by Elizabeth McCaughey identified areas where imperfect or impartial care is given. Not enough care generally, rather than too much care, but not the correct care. But when examining other countries that have attempted to use government-controlled guidelines that are mandatory to eliminate waste and provide better care, what the RAND study found was that the same proportion of inappropriate or wasteful care was found even in the government single-payer system. There was simply less care, but often patients who needed care didn't get it.
So are there ways to save money in the American healthcare system?
I was trying to explain that government controls are not the way to do it. I am going to answer the question.
You're probably not.
One of the most important things is to encourage people to lead healthier lifestyles. Preventative health care, because about 80% of preventative health care actually adds to cost. We do those things because they save lives, not because they save money. Things like mammograms, for example. But so much of the cost of care in the United States is related to renal failure, diabetes, heart disease, where changes in behavior could have a major impact on the cost of care. And I would encourage schools and the nation to do as much to educate people about proper eating as we did and succeeded in educating Americans about the dangers of smoking.
And Congressman, thanks. And Congressman, on sort of the opposite note, I mean, I think that part of the abiding concern with healthcare reform is that people like you say we're going to find $40 billion in Medicare and it won't hurt a bit.
Yeah.
And people find that hard to believe. And, it expresses itself in different, it expresses itself in different arguments. But I think people basically find it to be hard to believe that there's going to be all this restraining spending without any effect on care to patients. And why isn't that rational?
Well, actually, critics of Medicare are schizophrenic on this, in that they say, well, Medicare is so great, don't cut a dime, and then they say there's inefficiencies and waste. I agree that there is 10% that we could get in terms of the increase in growth. And unlike what Betsy keeps saying, it's not it's not a net cut. It's a $433 billion net increase. But some of the things that we do are just wrong-headed. I described a couple of them while I was standing there. We do nothing to compete for better prices for seniors in Medicare. We don't do that, and we ought to do it. We do very little. It is interesting to hear Betsy talk about how we need to come up with things to have people change their lifestyles, and yet every section in the bill that has the government aggregating information, she says there's going to be a mandate, you're going to cut people if they don't do those things. We need to be smart. We in this group are the insurer of about 65% of the country. Between the amount of money that we have in Medicare, Medicaid, and the other things, and the amount of employees of the federal government, city, and state governments, we're trying to save money for ourselves. I don't believe what Betsy says, that you can't get any savings out of Medicare. I do believe. I believe that you can. Now, she believes that 500 is too much. She hasn't said a dime of what she would get. I think you do. Now, when she was lieutenant governor, she proposed $1.5 billion out of Medicaid and said it was going to be out of efficiencies. So apparently in 95 we can do it. I think we can do it in 2009 as well.
Would you like the last word?
Yes, I'd like to refer to the Congressional Budget Office initial scoring, which suggested that only 1% of the $500 billion in future funding reductions under Medicare would be because of eliminating waste and fraud.
Except I said efficiencies. I said efficiencies. Things like negotiating for best price, things like encouraging best practices. I said efficiencies. Waste and fraud is not.
What happened? Do we have time for another question here? Well, thank you. I guess one I think that's sort of broader question. Came from a doctor in the audience. Is whether, on a sort of broader level, you think that the employer-based healthcare system, is worth keeping, should be kept, is the ideal way to run things?
Nope. Since you start, let me start with this one, since this is kind of in my wheelhouse. The answer is no. There is no real wisdom in the employer-based. Why should a shoe store on the north side of Queens Boulevard that decides to offer health insurance for its workers at $10,000 an employee, who's competing against someone else selling the identical products on the south side of Queens Boulevard, but who decides not to offer insurance, to let those workers go to the hospital emergency room? Why should that be left to the individual employer and how they feel, what kind of efficacy they feel with the policy? The Medicare system is not employer-based, obviously. I mean, it is to some degree that we pay based on the salary we make throughout our lives, but it is not up to an employer to decide what the coverage is that you should get. The idea that one employer should be making a decision in one town on one scale and competing theoretically with another one is just not fair. My proposal would do something different, and it would say, you know what? Let's let employers, let the guy who sells shoes sell shoes. Let someone who makes cars make cars. Let's let entrepreneurs do what they do well. What they don't do well is sitting and wrestling with paperwork for insurance companies. Medicare at 3.5% overhead actually does that. The argument for getting away from the employer base.
And I think the reason that the way that other Democrats rejected that argument was because the majority of Americans consistently say they're happy with the health care they get. And I wonder, you're willing to kind of disrupt that?
No, here's what I got this. First of all, the mythology that people like their insurance company. They like their doctor. No one says, oh, my Blue Cross, I can't wait to call them. They like their doctor. And I got to tell you something, I know the way to plan is, the only difference is where the money that's in their pocket, how it gets to their doctor. It's whether or not they bounce it off of an insurance company and say take 20%, or it goes directly there. Under Medicare, you have complete choice, something you don't have insurance companies. Under Medicare, you can choose the hospital you go to. You don't have that in an insurance company. You will not see any, you can theoretically do it tomorrow. The only thing you'd see is that portion of the pie chart that went to profits now can go to improved care, tax cuts, reducing the deficit, or anything else. It doesn't go into the pocket of insurance companies. But the reason the president changed his position on it is very simple. When you're taking on the insurance lobby, it's hard. When you're taking on the status quo, it's hard. But we did it 44 years ago with Medicare, we should do it again.
The employer-based system is a phenomenon of history. It's a result of the post-World War II economy. Nevertheless, it's undisputed that we have the best medical care in the world here. The best measure of medical care in the world. If you have a serious illness, what is your chance of surviving it and renewing your life? And there's no question, if you look at the Concord 5% study and cancer, if you look at the National Bureau of Economic Research July 2009 report on heart disease and stroke, you will find that the United States is in the top 3 for recovering from almost every form of cancer, heart disease, and stroke. So, and those statistics reflect the experiences of all patients, not just those with insurance. Now, Anthony said before that we should look at other countries with single-payer systems. We should just look at Medicare. And I've already made the point that Medicare is subsidized by the private sector. But to say that the United States would not suffer from the same poor performance as other single-payer countries is allowing wishful thinking to triumph experience. If the other countries haven't been able to do it well, why risk subjecting our patients to it?
Because we're America and we're the best.
Do not be distracted by this discussion of theoretical issues like a single-payer system. Congress is moving much too fast toward a bill. I'd like to hear whether Anthony is going to vote for that bill, even though it will devastate New York's hospitals, New York's patients, and New York's healthcare workers.
Another question from the internet for you. I think the audience had its chance on the internet a little while ago. Sorry. That's what I'm told. But which is that your current work has to do with I guess best practices in medicine, reducing infectious diseases. That's been, I think, some of the people, the guys who are on that slide before, is something that they've written about as well. And there's a portion of I think of most of the legislation that's coming through that would allow Medicare to reward doctors and hospitals who specifically reduce infectious diseases in the hospitals. And I wonder if that level of government interference, is something that you think is an effective way of doing that?
Yes, I'd like to address that. In fact, the Committee to Reduce Infection Deaths is largely behind that effort. Medicare is already has a new rule in place that will not reimburse hospitals for the cost of treating infections that should have been prevented. We pushed very hard for that. Hospital infections kill more people in the U.S. each year than all the cases of breast cancer, all the cases of AIDS, and all the car accidents combined. And they also add about $30.5 billion a year to the nation's health tax, costs that should be prevented. So I'm very much in favor of rewarding hospitals for following proper safety measures to prevent
and punishing them when they don't?
Punishing them by forcing them to treat the infection without being reimbursed for it. But here is the difference. In the area of patient safety, there is only a little controversy. Everyone knows that clean hands are better than dirty hands, that replacing the privacy curtains can protect patients from infection. There may be some controversy about when screening for methicillin-resistant Staphylococcus aureus is important, but generally there's very little controversy. Now move to an area like cardiac care, where even when a consensus group has devised a guideline on how to care for a particular a patient after a particular cardiac event, there's always a minority opinion as well. And when you do more than simply send the research to physicians, when you actually penalize them for not following the guideline, you put them in the position of treating a patient who is not average, who has comorbidities, who should not be treated again according to that guideline. You put the doctor into the uncomfortable position of being penalized for not following that guideline. And if you ask specialists in this hospital or anywhere else how disruptive that is, they will tell you.
Thank you. And thank you.
I think in that answer, you saw the inherent contradiction in a lot of what Betsy said. That Medicare, a 44-year government-run program, has come up with best practices, incentivizes people to follow. That's all that the bill that she has, the version of the bill that she has in front of her is to do. How come it is, when we try to do that, to aggregate best practices, how come that when we do it now, it's that we're trying to kill senior citizens? And yet for the last 44 years of experience, whenever we've aggregated that information, it hasn't been used for that purpose. So when people try to scare you about the public option, think to yourself, we now have some experience. We don't have to fantasize about what it might look like. We know, for example, that it's very efficient. We know, for example, that we don't have to put a lot of extra money in for profits and overhead and the like. We know, for example, that we've been trying to find best practices for the longest time. This bill seeks to do that more. So you can't say, well, yeah, for 44 years, and in this particular case, the government has been fine administering Medicare, when we have no experience in that 44 years of the federal government doing the draconian thing that Betsy and some others have tried to scare people into thinking is going to happen. Don't worry. All we're going to do is provide care for people who don't have it, provide better care for you, and God willing, save the taxpayer lives.
Thank you so much.
$22 billion
Thank everybody at the panel for being involved with this. I'll turn it back over to these folks from Field 21C.
So we want to thank all of you for coming. We especially want to thank our guests and our wonderful speakers, Congressman Weiner and Dr. McCaughey. Shout out to Ben Smith, the moderator. Final reminder, we'll be at Mercury Bar at 3rd Avenue and 33rd Street for anyone who wants to continue the discussion over cocktails. Thank you all for coming.